I'm really excited about our next presentation and our speakers. We have two speakers who have done groundbreaking work in the behavioral health field, and they're going to be talking about a topic that is actually part of a project that the Kansas Business Group on Health is working on. It's called the Path Forward Project, and it is actually through the National Alliance of Healthcare Purchaser Coalitions, of which we are a member. And it really is focused on improving access to care and the quality of care in the behavioral health space, both mental health and substance abuse. There are 5 focus areas that we're working on: measurement-based care, mental health parity, telehealth, and network adequacy. And then the 5th one is collaborative care or integrated care. And that's the integration of primary care and mental health. I have been promoting that, coming from a mental health background myself, for years. And so I was really excited to see this be part of a national project. But we're really honored today to have both of our speakers. We have first Dr. Carol Alter, who is the System Medical Director for Behavioral Health at Baylor Scott and White Health. And then also joining us today is Dr. Henry Harbin, who is a psychiatrist with over 40 years of experience in the behavioral health field. He has held a number of senior positions in both public and private healthcare organizations, including serving on President Bush's new Freedom Commission on Mental Health. And so, Dr. Alter and Dr. Harbin, I am going to go ahead and turn it over to you. And I can't remember, you were going to do your slide deck. Is that right, Dr. Alter?
I am.
Okay, perfect.
Great.
I think you should be able to do that.
1 second, and I will, let's see, I'll pull, hopefully it will go. Great.
Super.
Hi, everybody. And thanks, Shelley, for that lovely introduction. And I'm excited to be here with Henry as well. So in any case, I'm going to talk about some of these topics. And if people have additional questions, please feel free to ask, or we can also provide additional information. I think the important thing to note is that the path forward is really aimed at understanding how to manage behavioral health risk, which is very common, obviously within all healthcare settings and primary care, and these are obviously the most expensive patients. And so when we start to talk about this, I think it's really important to understand that many patients within primary care are at risk of having a behavioral health disorder, and often are not even diagnosed. So things like current or prior use of a behavioral health medication, diagnosis of more than two chronic medical problems with or without a behavioral health diagnosis, participation, attending, going to the hospital more than one time, or visiting the ED, all of these kinds of things are, I can't see part of my slides, as well as taking more than 4 of any kind of medication. All of these kinds of things put you at risk for a mental health disorder, which with all of the sort of needs as well as costs associated with it. Let's see if I can get this to move. Sorry. And these are the most expensive patients that are really seen within any health plan or within a population. They are 2 to 3 times more expensive. These are folks that end up being seen primarily in primary care. They're not really seen within mental health settings. And even when they're referred, only 50% of them show up, and they have on average 2 visits. So what we know is that these are folks that in fact can be seen within primary care and can be treated within primary care. And I think that's a really important sort of starting point in this conversation. The other thing, though, is that while they may be in primary care or seen in primary care, they go undiagnosed 85% of the time. So if you look at what you would expect the prevalence to be, if you look at population-based epidemiologic data, you find that patients with arthritis, about 1/3 of them should have a mental health disorder, but yet only 7% of them are diagnosed. Asthma, 60%, et cetera, down the line. And what you see is that less than 10% of them are ever really diagnosed, which means that we're missing about 85% of those diagnoses when they do show up in primary care. Again, these are expensive patients. The costs with behavioral health diagnoses are much greater than without behavioral health diagnoses. And if you look at the data associated with sort of PMPMs, again, looking at these populations, we're seeing that they're somewhere between 2 and 4 times greater than those without mental health disorders. So I'm going to shift gears a little bit to talking about the two pieces of the path forward. One is measurement-based care, and the other is the collaborative care model. Both of them are really critical and I think doable in terms of changing the way that we approach mental health care, and again, focusing on both primary care as well as within specialty settings. So you all know what measurement-based care is. And in fact, the last 2 talks, we're talking all about measurement-based care. It was about response to diabetes and what are the blood glucose levels and HbA1cs. That's measurement-based care. It's what we do every day in medicine. It's identifying, diagnosing illness and progress against treatment by looking at objective measures like blood glucose, HbA1c, blood pressure, et cetera. So it is by definition the use of repeated validated measures to track symptoms and outcomes in the clinical setting. And we do that within behavioral health by using patient-reported outcome measures largely. The primary objective here is to drive clinical decisions and help treat to target. And the use of measurement-based care and routine practice is known to improve outcomes. And at this point, there have been a number of incentives to doing that, including reimbursement opportunities and accreditation programs requiring the use of measurement-based care. There are a number of validated rating scales that can be used in this area to address everything from depression and anxiety, suicide risk, eating disorders, et cetera. So that in almost probably in every single behavioral health disorder, there is a measure that can be used to help with screening, diagnosis, and tracking treatment over time. The study, The Tipping Point, was published in 2017. Henry was one of the authors on this, and it really was a tipping point in essence, because it identified through looking at a number of studies that even with the utilization of measurement-based care, that outcomes improved 20 to 60%. And that there was a nearly 75% difference in remission between patients receiving it versus those receiving usual care. So it wasn't really about, it was the act of doing the measurement, which then leads to a behavior of the provider of noticing in a more objective way when things are improving or not. In physical health conditions, we wouldn't think about treating or monitoring most conditions without actually having some objective measure against it. And those measures do exist in behavioral health, but they're currently not really being used. The accreditation standards that impact care delivery, such as the Joint Commission or URAC, are used by many providers, health systems, health plans, health systems, provider groups, et cetera. They accredit a number of different things, but in fact, there are now accreditation standards in the Joint Commission, which look at suicide. That's a broader group of plans that are evaluated, and they say you must be looking at suicide safety issues, et cetera. But in 2018, the Joint Commission also added a standard which said for behavioral health provider groups that they should be utilizing measurement-based care across all of their work. So that's a requirement if you are a freestanding mental health clinic or provider group. And URAC recently added a standard that again focuses on the delivery of measurement-based care. I know that you all are probably also very familiar with quality measurement, which is different than measurement-based care. So measurement-based care is the utilization of these validated rating tools in a clinical setting. But quality measurement, as you know, provides benchmarks, allowing comparison across organizations. It's important in really determining, when you look at a health plan, when you look at provider groups, whether or not they are meeting those benchmarks and how do they compare against others in the community. And those measures, again, are more population-based. They may aggregate data like what is found in measurement-based care, but they're two different, they're sort of two different standards. Examples in measurement-based care, we talk about screening for depression, anxiety. Those are the PHQ-9 and the GAD-7. Those are the names of the scales. And blood pressure, that's measurement-based care. But quality measures, those are things that come out of HEDIS or the Medicaid core set or MIPS. So they're really two distinctly different ideas. And in order to get a screening measure for depression to be a quality measure, it requires utilization in standardized settings and data collection and all of that. There currently is a measure for depression. There are measures for depression remission and response and screening, but those are the only outcome measures that we have in behavioral health currently. But it is easily possible with time and resources to convert much of what we already do in measurement-based care and could be doing into quality measures. But again, they're different things. I'm going to shift gears a little bit and talk about collaborative care, which Shelley mentioned as being important in the path forward. It's really the way, when you think about in primary care, as I mentioned at the beginning, that the majority of patients with behavioral health disorders will be seen within primary care, but they're not diagnosed necessarily. And we also know that their treatment outcomes are not nearly as good as they could be. And so collaborative care was really designed to address those issues in primary care of screening, diagnosis, and treatment and outcomes by developing a systematic approach to identifying and treating patients with behavioral health conditions. Depression, anxiety, substance use disorder, all behavioral health conditions really can be sort of addressed within this model. It involves really a team around the primary care provider. You can see in the slide a picture which shows that sort of all arrows point to the PCP and point to the patient. And there's been over 80 randomized controlled trials showing improved access and outcomes, value, and the outcomes impact not just mental health disorders, so improvement in anxiety and depression, but also reduction in markers of chronic disease like diabetes or hypertension, reduction in costs, ED visits, hospitalizations across the board, not just mental health, a decrease in mental health costs, but decrease in all healthcare costs. And in 2017, there were new billing codes that were approved and to pay for this. So there's a revenue stream against this, and whether you know it or not, the payers in your community are actually do actually pay for these codes, whether or not providers are actually delivering the service. As I said, the data really shows that there is a 50% or greater improvement in depression at 12 months in this study, which really got the ball rolling in terms of many of the other studies that have occurred, as well as understanding the impact from a cost perspective, and that this was the most effective behavioral health intervention sort of ever shown out there. And so, and really, obviously, this is a huge population issue. And so this was very compelling evidence for CMS and other payers to say, yes, we will pay for this, the development of this. So how does it work? The way it works is that a patient is identified by the PCP In fact, the patient could be identified prior to a PCP visit with the kinds of risk factors I started with. Those kinds of risk factors could be presented to the PCP, and the PCP could be alerted that the patient may be at risk, or the patient may come in with a screen for depression. The PCP will then say, I'd like you to see our team who helps me with this work, and I'm going to refer them to you. You to them, and then the care manager, who's a behavioral health care manager, usually a social worker, could be a nurse, will engage with the patient and begin to do an intake chart review, collect a significant amount of information from the patient about their mental health symptoms, as well as their medical issues, etc. The care manager then reviews that with a psychiatrist. So this model requires the use of a psychiatrist as a consultant. The psychiatrist does not see the patient. The psychiatrist hears the story about the patient, and then together the psychiatrist and the care manager come up with a care plan, which includes a diagnosis, a likely diagnosis, and recommended treatment. That then goes to the PCP, where the PCP reviews the report that is given and ultimately makes the treatment decisions about what they want to move forward with, and usually they will go ahead and take the advice of the psychiatrist. The PCP then continues with the medical treatment of the patient, discusses the diagnosis, the treatment plan, et cetera, with the patient, but it's the care manager in an ongoing way who will support that care plan, will provide low intensity kind of psychotherapeutic interventions, et cetera, and will document all of these. Will document the outcomes in the electronic health record through a registry, which and it's required that on a monthly sequence that every patient does get one of those validated rating scales to be able to track that outcome. So we treat to target. The care manager discusses cases on an ongoing basis with the psychiatrist. If patients aren't getting better, adjustments are made, other recommendations are made, et cetera. And the idea here is to obviously improve outcomes for patients, which it does. Just to give you kind of a sense about where things are, since the implementation of the collaborative care codes, there's been, a significant uptake in a number of different places, usually in very large health systems and aggregated primary care practices. But it is not an easy thing to do immediately. It takes planning, development of infrastructure within those health systems, hiring of care managers, et cetera. So I lead efforts at Baylor Scott & White, which we have over 300 primary care practices and 2 million patients that we care for. We do not have a very large primary behavioral health program. We employ less than 200 behavioral health folks. So this is really our answer to how we're going to address this population. We've started our rollout. We're in 2 large practices. We'll be in another 6 or 7 by the end of, by July, and we'll be in 300 practices by the end of 2022. So, that is certainly, I think, an example. There's a number of other examples at Northwestern, University of Pennsylvania, Cleveland Clinic, the Mayo Clinic, University of Washington, where this was started. And there's numbers of them that have been started across the country. As well, not only can health systems or large practices build these things with help and expertise from either folks that they have on board or external consultants, but there are also turnkey vendors who can help systems and practices do this, so that practices or health systems don't need to build this whole entire thing. They can work with organizations that have been doing this successfully for all practice sizes, small and large. So with that, I'm going to turn this over to Henry. And I think Henry will talk a little bit more about how you as employers can become involved in this and take these first steps to really make sure that that the health plans are covering these activities and that the providers are actually delivering them. So Henry.
Thanks, Carol. Can you hear me okay?
Yes.
Good. Okay, so a couple of points I'd add to what Carol's excellent presentation. One is, why is the path forward in this alliance with the National Alliance and the Kansas Business Group, et cetera, picked collaborative care and measure-based care in the medical system to make it a priority? So a couple of reasons for that. We have pretty good data that shows that people with mental health or substance abuse problems and disorders have about a 10-year lag between the time they show symptoms of an illness before they are diagnosed and treated. So this is quite amazing, that it takes this long. I use this particularly in the time of COVID. Could you imagine if the Surgeon General of the US stood up and said, well, I know COVID's important for testing and tracking, but it's going to be about 10 years from the time you have a fever and a cough before we'll diagnose and treat COVID. But that's the case today with anxiety disorders, depression, schizophrenia, et cetera. So one of the important things is this screening for these illnesses with the rating scales that Carol has presented can only happen in the general medical system. It can't, by the time you get to see a psychiatrist, psychologist, you've been diagnosed and you've probably had symptoms for years. So rolling out measurement-based care, which has both screening and tracking of outcomes, is a critical part from a public health point of view to ever having a big impact on the public health outcomes for people with mental health disorders and substance use disorders. Another reason is that the majority of patients with mild to moderate mental health and substance use problems get all of their treatment in primary care. So primary care docs prescribe the vast majority of psychiatric medications, even if the patient is maybe seeing a psychologist or social worker for therapy. And unfortunately, it's rare for primary care docs to use these measurement-based care rating scales when they treat mental health and substance abuse problems. It's routine for them to do this with almost all medical disorders. And it's very rare for mental health specialists to use these tracking tools, these quantifiable, validated measurements. So the view of the path forward and many other public health officials is that without making some changes within the general medical system, both for the better effectiveness and screening, we're not really going to have a major impact on these illnesses, particularly those with mild to moderate. My guess is that if you're for the employers on the call, the majority of your employees and family members are probably getting mental health care or substance abuse care almost exclusively from primary care docs. And this is not a criticism of primary care docs. They have a lot on their plate, but they can play a critical role in early identification and effective treatment. And with this collaborative care model that Carol has described, they can achieve the same similar outcomes, particularly for mild to moderate illnesses, which make up the vast majority of these problems, as effectively as seeing a specialist. So this is why we think this is one of the most core important things for the employers and for plans and providers to do. It's very important, as another major, as Shelley pointed out, priority is to expand access to behavioral specialists. But that alone, we don't think is going to solve the public health outcomes for these illnesses, for suicide, opiate addiction, you name it. So we view, actually, I do, and many other people that work with the path forward, that probably the most important priority, if you really want to have the biggest impact in the short run on people with behavioral disorder, is to implement measurement-based care in the medical system and collaborative care. So we know now that most of the commercial insurers are paying these collaborative care codes, which came out in 2017. Both Carol and I worked on that with a team of people to get these codes created by CMS and then the AMA. So the collaborative care model, as Carol pointed out, has been used now for over 2 decades in large clinical systems, mostly, staff model like Kaiser, VA, DOD, et cetera. But the codes allow for this to be used for anybody, small practices, PPO arrangements, et cetera. So the commercial carriers are paying, Medicare pays because they issue the original codes, and about 17 Medicaid agencies are now paying these codes. However, and I think, Shelley, I don't know if you know this, but we think that the National Alliance and the regional business groups actually played a role in getting more of the commercial carriers to pay these codes. So they are now. Our bigger challenge is many of the medical groups don't want to do this. You know, they have a lot on their plate, big medical system, primary care providers, they're busy treating, you know, every disease there is. And they are the backbone of our healthcare system for many things, including mental health. So really the issue focus now is to try to get more help and support for things like what Carol's doing at Baylor Scott White, to provide support for provider systems to get measure-based care and collaborative care going. And so one of the things that employers can do is to add or be clear with their TPA, with their health plan vendors, that not only in addition to paying for the codes, providing some technical assistance and training and support to the medical systems in your area would help expedite this. We do have plenty of examples of people setting up small practices or larger practices, setting up these services, both measurement-based care and collaborative care, in a fairly timely way. I think Carol points out, if you were to, roll this out for 50 hospitals in the Baylor Scott White system, which is the largest system in Texas, I think, Carol, may take a year and a half, but we know that this can also be set up on a smaller scale with some practices within 3 to 6 months, and then build from there, which is really what Carol's doing there as a lead person within that system. So we would hope that employers would look at the possibility of working with their health plans partners to start providing some of this technical assistance training and make it a requirement that this be one of the things that is done as made a priority. So the other is, of course, the more that the quality measures, as Carol pointed out, are required by Joint Commission, URAC, and others, both for medical and behavioral providers, it, I think, will require an additional incentive for medical systems to adopt collaborative care and roll it out faster, as they do for diabetes. As you were just hearing that excellent talk. We're looking to basically replicate that and have this become a standard. So I just wanted to add a few of those issues about where this priority of helping make changes in the general medical system fits in the broader priorities of the path forward. And unfortunately, really for many mental health and substance abuse leaders, they have not focused on needing to have changes in the general medical system. But it's clear from a public health point of view, we're not going to achieve what I think we all want, is to reduce suicide rates. We want to reduce deaths from opioid disorders. We want to improve the outcomes for folks. And this is like probably one of the most important things we could do. So Carol and Shelley, I'll stop there. And I don't know if we have time for questions, or Carol, you want to add anything to what I've said?
No, I think you hit the points, but open for questions.
Yeah, please, folks, send questions. You can either just turn your audio on and ask them, or put it in your chat box. In the meantime, I actually do have a couple of them. I will tell you that what we have found here is that we have very little collaborative care, and I would say probably very little measurement-based care, at least in the behavioral health space. And, one of the things that we have heard actually from a local PPO is that it's just too expensive to implement a collaborative care model. And I know that there's, for example, the National Alliance is working on doing some study on that and the cost to actually do it. And I've heard different numbers that, it takes about a year, et cetera. But do you have any sense about that relative to the cost if a primary care group, wanted to start that? Any insight into what that might look like from a cost perspective?
Yeah, Shelley, I would add a couple. I'm sure Carol would also, but there are some startup costs when you're first rolling this out, like any other program in healthcare. till you get the people hired in the building. There are some vendors, by the way, external vendors who can help do this, and they're like turnkey organizations, and will take a lot of their reimbursement out of the billing of the codes. The valuation of the codes, if as set by Medicare and is being used by some, but not all commercial carriers, was based on mature collaborative care programs on the average cost, and they are reasonable. And there are systems implementing by those codes, once they're up and running, that are breaking even and maybe making a small profit. But our issue here is to cover all the costs, right? And it has some administrative costs for the practice. So some practices have started this and they only refer a few patients to this. I think in that situation, you're probably going to need a subsidy. We know from some of the mature programs, and University of Pennsylvania is a good example, 15% of all their primary care patients are now referred into this program, so into the collaborative care program, and they're breaking even. That is a big system, big academic system. But we do think, and Shelley, that's why I brought it out, I think that if employers and plans should look at the feasibility of providing some coverage for startup costs, just as the government did when EHRs were rolled out. Some health plans have done this to set up ACOs and primary care medical homes. All of this, and by comparison, when people say it's too difficult, some say that. These are 4 codes. This is much simpler than rolling out an ACO. It's much simpler than doing a primary care medical home model for multiple chronic diseases. This is similar to that. So it's all relative. And I would point out, because there is value in this. If you're on a risk adjustment for care costs, this is probably one of the few things you could do that actually would reduce your total medical costs. And also, of course, in addition to adding value in terms of better outcomes. So there are a number of reasons, but there are challenges to the startup costs from some, even though some of the smaller practices are using a couple of these vendors where they're basically helping, and they'll do the whole thing. They'll provide the care manager, the consulting psychiatrist. One thing to point out, I think, for rural practices and smaller practices, is this is really the only integrated model that's feasible, because it can be all virtual. So what Carol's described, a bigger practice can hire care managers and have them on site. But if you're a small practice or you're a rural practice, that's not feasible. 50% of all the counties in the country have no mental health or substance abuse professionals in the county. So having a model where they co-locate is not feasible, but this can be done all virtually. So those are some of, Carol, you probably want to add more to that. But
I think that what we've seen in the field are a few things. Number one, I think Henry's right. So if you determine that there's a new code for bone densitometry testing, and that there's actually a revenue stream for that, and that within 6 to 12 months, you'll pay for the cost of the capital expense, et cetera, then people say, let's move forward. So it's like any other decision that you make in healthcare, which is, are there opportunities here to address issues that are important to us? And so I think from a cost perspective, in fact, the modeling suggests that that in a very large system, it's probably a good idea for the system to build the components itself. There are consultants out there that can help you do it. And in fact, you will break even within 6 to 12 months if you have help sort of shaping it. University of Pennsylvania is doing okay with it. Northwestern is. There's other places that have done this and built it themselves. Epic actually has tools that are easily sort of tweaked to be able to, to do there's lots of population health tools out there that can be used for this. There's lots of care management tools out there. So the answer is, if you're a large system, it's worth looking at the projections and the financial model to figure out if you want to do it. I think the other piece that's important to note is that when I started to do this work as a chief medical officer of one of the vendors, Mindula Health, and at the very beginning, right when the codes were established, there wasn't a lot of significant amount of interest. But I'll tell you where the interest came. The interest came, and this is exactly what's going on at Baylor Scott and White. The interest came because of being at risk. So you all as employers in many cases are self-insured. This is why Henry's point about helping with this as an employer and incentivizing the plans makes a lot of sense, or having your TPA do that. It's when you have the risk for that patient population that you know that these are your most expensive patients, that if we don't address these issues, they'll be even more expensive, et cetera, et cetera. And I think that's where the real value of this is. There have been some really sort of impactful actuarial analyses which show that between 10 and 20%, that when you implement the model, that there are reductions in total health costs of between 10 and 20% of your population. That's a really important thing. And I think that, again, if you can take the long view, if you understand this population is yours to manage, the risk is yours, the hospitalizations are yours. I mean, think about it. You know, one ED visit, $3,500. That's like, you know, that's 3 or 4 patients who could have had collaborative care. So I think that it's really the perspective, and where I think we've seen the greatest amount of interest has been when people are taking risk.
I would add to that, I think it's a great point, Carol, Shelley, along this medical cost savings thing, the Path Forward actually commissioned a study released a couple of months ago with Milliman, where we looked at on a patient, it was a claims analysis of 20 million people, and looked at the impact of behavioral disorders on total medical costs. So in that study of these 21 million people, we identified the 10% of that group that were the highest cost users of all medical, behavioral, everything. And that subgroup, the high utilizers, right, basically drove 70% of the total medical costs of these 21 million people. But then we looked at, and this was a commission, as I said, by the Path Forward, the subgroup of that 10% that had behavioral health problems, 57% had a diagnosed mental health or substance abuse disorder. And that subgroup drove 44% of all medical spending for the 21 million people. And obviously most of that medical spending was physical health. So you have now, and if you carry that out on a large population basis, let's say, of the 21 million people in the original sample that were looked at, their claims, 6% of that population had combined medical behavioral disorders, and they drove almost half of all the medical costs. So we, as Carol presented the data, we know by whether it's cancer, heart disease, if you add depression or alcoholism or whatever to that, and they don't have to be severe. One of the, I think, misunderstandings of this, that the only costly people are those with severe mental illnesses, that's not accurate. The majority of the costs are people with mild to moderate illnesses, the ones who get a lot of their treatment in primary care. So having an impact on that subgroup would have a tremendous impact on total medical spending. And also, we hear from a lot of primary care leaders that have done this and are doing this, that this subgroup of patients are often their most challenging. You know, these are people that are, diabetes, have 2 or 3 chronic illnesses, they're depressed, they're miserable, they're difficult to manage, they have a hard time. So when they have brought in these behavioral care managers or the consulting psychiatrists, it helps them with what is a challenging patient population. So in addition to savings and better outcomes, there's kind of another practical aspect. I actually had the medical director for Kaiser for the country, the non-psychiatrist medical director. This was 2 or 3 years ago. We were on a panel together. He got to talking about collaborative care. So we've been doing collaborative care in Kaiser for many years. And my primary care docs tells me we will never go back to the old way of doing this.
Mm-hmm, mm-hmm. Well, and we do have a question. I'm going to get to it in just a second, but I will say that here in Wichita and Sedgwick County, the public entities, the federally qualified health centers, are so much further along than any private, at least that we have, had access to in terms of any primary care clinics. And so I applaud them for that. I don't know if they have any data yet to show outcomes, but, as I say, I have tried to promote this for years and years when I was back in the mental health world. But I do want to get to our question. Kirsten has a question. Are you aware of any employers utilizing this method or a similar method in an on-site clinic versus utilization of community care? If so, any comparison on outcomes? Great question.
So if you mean where there is an employer has an on-site primary care clinic, let's say, I don't know of any. I do know that CVS Aetna is in the process of rolling out primary care sites on all of their pharmacy sites. And they are actually looking at adding a collaborative care component to all of those clinics. I'm sure there are some, Shelley, Carol may know of some that have actually added some level of collaborative care, integrated care to those clinics, but I'm not aware of the specific examples.
So we are an employer, and we do have we do have some on-site clinics. We also contract with other employers who have on-site clinics, and we will be providing care for the external, and we are providing care for the internal. I also know when I was at Georgetown that the World Bank clinic that they staff included collaborative care. So that was actually very intentional that they would build collaborative care. So that's my own anecdotal experience. In terms of outcomes, I've looked at hundreds of programs and their outcomes, and in general, they're always the same. We see improvement, and 60 to 80% of patients are improved, and they're and so and their improvement rate, their remission rates are, in the 10 to 20%, and response rates close to 40%. So I've never seen that vary. So I don't think there have been any specific studies to that effect. But I would defer to Henry to let you know that this has been studied so much that we don't need more studies. But Henry, I don't know if you want to.
Right. Yeah. Well, I think, look, there are 80 randomized trials showing clinical improvement in a variety of different settings. Medicaid, by the way, Shelley, as well as Medicare, patient beneficiaries, as well as commercial. I don't know that we need to study this again. I mean, this is, people may want to do an administrative tracking that this is being done well. That would be great. But like UPenn, where they've done this thing now for the last several years, they're tracking their outcomes. Like Carol was saying, a lot of places do that, not in a randomized trial, but it just for their own things. And the results are quite good. Like I say, they mimic in similar, better, having pretty good specialty behavioral care. You're having some similar kind of outcomes for these patients. So.
And so I wanted to ask also in terms of for the substance use disorders, because that, I'm not even sure what I'm asking here, but it seems like that the collaborative care and obviously measurement-based care, yes, on the substance use disorders, but in terms of the integrated care, is there as much success in terms of the outcomes for when they're, and oftentimes there's, comorbid, but can you speak to that at all in terms of kind of the substance?
Yes, there are some studies where, pure substance abuse patients using this model improve. You have to remember, I think something like 60% of people with mental health problems have comorbid substance abuse problems. So they're partly identified in some of these 80 randomized trials. There are another value of this, and this is actually, there's a kind of a large trial going on now, Shelley, where, partly we have a shortage of doctors and nurses who will provide medication-assisted treatment for opioid disorders. So, and many primary care doctors and other medical have stepped into this, thank goodness, and are offering. So those are like a specialized program, but the collaborative care services can be billed in addition to that. So like ASAM, they were one of the ones who really lobbied for these codes, because they basically give a primary care team additional behavioral resources to handle whatever problem they're handling, right? So substance abuse, mental health. I think a part we don't talk as much about the value of the collaborative care is it gives you behavioral health care managers, virtual or on site, that can help find specialists. So a number of, they're anywhere from 20 to 50% need to go see a specialty substance abuse program or a specialist psychiatry program or a specialty, et cetera. And if you don't have any staff that can find a therapist, I think about the situation benefit managers are in with employers. They're often called, and we hear from many employers, large and small, they're having to case manage mental health and substance abuse case because they can't find anybody in network. Well, you put that burden on a primary care clinic. You could see why they don't want to treat these people, or they don't want to screen them, because then they got to find somebody, and 50% of the patients they refer to a specialty program don't follow up. But it's a lot of work, and that you now have somebody on your team whose job it is to find a specialist.
Right. Okay, great. Thank you so much. We have another question. What pushback concerns might an employer encounter when encouraging local PCPs to engage in collaborative care? And is there anything employers can do to address or ease those concerns?
Well, I think we pointed out some of the reasons: cost savings, that if they have a value-based arrangement, or either a primary care type medical home type program or an ACO or another where they're at risk, their most expensive subset of patients, they're basically ignoring the behavioral health part without doing something like this. I think there's a cost reason, there's an outcomes reason. I mean, I think one of the interesting things to me, because I've heard from really large, prestigious medical systems, Shelley, have told their regional business coalitions, we're too busy to do this. Now, I may insult some people saying this, but it's not my intent. Well, I think it would be one thing if you were going to a big medical system and say, we have millions of thousands of untreated mental health substance abuse problems. Would you take them on and start handling them? Well, that would be a very fair statement if they said, I'm full, right? I've got all the patients, diabetics and others that I can handle. To me, that's a valid response, but that's not the situation. They're already treating these people. They're screening or not screening, they're prescribing most of the psych meds. So to me, this is an issue where you might say back, what would you say to them if they came to you and said, well, we have thousands of diabetic patients in our population. We've decided we're too busy to measure their blood glucose levels. We're too busy to bring them back and treat to target. How quickly would you say okay or not okay? So I would have a variety of answers. Some are more a carrot, right? Like this is the right thing to do. And there's a lot of good things for the patients and families, but also for employers. So.
Okay, great. Thank you. We have another one. Once you find a specialist, it is difficult to get in and see them. Clearly, we are hearing that from our employers. There seems to be a shortage of behavioral health specialists in the Wichita area. Can you speak to this? And I'm not sure if, Diana, you're asking me or asking them. It's interesting because one of the things that I have heard, Matt and I are actually on the subcommittee of the Kansas Mental Health Coalition, the subcommittee on mental health parity. And there are therapists on there now. I don't think any psychiatrists, but psychologists and social workers. And they indicate that part of the struggle they have is that the carriers panel, they will not allow any more people on the panel. And so that, I don't know if that's related at all, but I don't know, Dr. Alter or Henry, if you have any specific response to that. I mean, obviously access to care is always an issue. We know psychiatrists, particularly child psychiatrists, are few and far between.
Well, I would say add to that a couple of things. I'm sure Carol would too. But so, there are 5 priorities in the path forward. One of them is better access to in-network behavioral health specialists across all levels, office-based, inpatient, the range. Yes, there are a shortage of psychiatrists and psychologists in network. There are a lot of them out there. They just don't want to be a part of a panel. So a core part of the path forward thing is, one, working with the plans to measure the levels of network adequacy and how much adequacy is there. We've heard from a lot, Shelley, despite this shortage, there are a lot of health plans that close their panels, which I think makes no sense at all, right? Mm-hmm. So one of the tools that the employers can use on this issue is we have a thing that the Path Forward uses called the Model Data Request Form. Basically, it's a request that the plans provide you, the coalition or an individual employer, the quantitative data about how much out-of-network use are there for mental health substance abuse compared to medical, for office and inpatient, et cetera. How active are your reimbursement levels less for behavioral health specialists compared to primary care for office codes? Based on these national studies that have been done, it shows that the out-of-network use for people with a mental health substance abuse problem, all other medical problems, is 30% sometimes, 40% sometimes, where it's 5 or 10% for medical disorders. There are lots of hard to recruit specialists on the medical side. Ever try to find a dermatologist sometime or a subspecialist in cancer? And the plans have done a great job bringing them in. They pay more sometimes, or they make it a priority sometimes. All we're asking, the path forward is asking, pay attention and make this a priority on the behavioral side. There are two other things. We view collaborative care and telebehavioral health care as one of the ways to help address this shortage. As Carol, as we just talked about, a lot of people can get great care, primary care, particularly with mild and moderate problems, totally from their primary care team if they're doing collaborative care. But telebehavioral health also adds a tremendous, now in the, the COVID era, this is now the norm, not the exception, and getting more in-network therapists. So we view the package of things here is what's important to address this shortage and difficult to engage behavioral specialists. Carol, you want to?
Yeah, I just want to say that, when we first started to talk about this, we always led with this idea that there was a shortage, which what that sort of seems to infer is that people need the psychiatrist or they need the psychologist. And I would argue, to Henry's point, that probably, again, only 5% of the population really needs specialty care that way. Maybe more people need psychotherapy to go along with, appropriate sort of medical management, but it's really a small number that need these services. And if you can manage them better with, at the outset in primary care, and that means getting a diagnosis, which is something that having the therapist down the hall doesn't necessarily do for you. I think that's really the key. The key is managing this like you would any other illness. And if you do that, then you really force yourself as a primary care provider and as a health system, have a good diagnosis and a good treatment plan and look at outcomes. And when you do that, I think it shifts the balance. That said, I think the points that Henry is making about availability of specialists is really a critical issue, even to try to get those 5% or 10% in. I mean, we still have to refer out 10% of the patients that get referred to us because they have a complex set of psychiatric conditions that their PCP really can't manage. And I can tell you, we spend months trying to get them into somebody because there really are, and people, especially now with COVID, they are not going to walk into their pocket, reach into their pocket and pull out $500. They're not going to do it. So I think it's a big issue. And I think what, Henry talked about with the Path Forwards approach. I of course also believe that there's a good reason to incentivize people to use measurement-based care. And if you're going to go and put people on your panel, pay them more if they're willing to do measurement-based care. So anyway.
Yeah, I think that I would agree with Carol. I think we do need more in-network, the whole range of services, and reimbursement is part of the problem. It's not the only problem, but we know from these other national studies that have been done, this is on average that psychiatrists, psychologists, social workers are paid 20 to 60% less than primary care physicians for similar or same billing codes. There's absolutely no reason for that. And the fact that one of the national surveys done over a 5-year period of this database from Milliman showed that over the 5 years, the reimbursement for office-based psychiatrists, psychologists, on average, these are hundreds of insurers it's measuring, right, was never got above Medicare allowables. Now, I don't think, this is for commercial payers. I think, I can't imagine any commercial payer that's paying its medical professionals the same as Medicare allowables or less. For substance abuse, what it showed is they were usually paying less than Medicare allowables. So in reimbursement is part of the problem. The employers have tools now that you all do as a part of you being part of the Path Forward to measure this and frankly require your TPAs, your health plans to not do that.
Right. And we're getting close to our time here, about a minute left. And I did want to reinforce that. And that's what we've been talking with our employers. We have primarily been working with 3 employers, and with COVID, everything slowed down. But really, I believe it is, quite frankly, incumbent upon the employers, the purchasers, to really begin to talk about that. And part of our role as a business group on health is to help empower them, if you will, to really push that, because it is, for me, most importantly, is the health and welfare of your employees. They're going to be better employees. They're going to be more productive. They're going to be happier, healthier, and it's going to save you money. So again, that's part of the thing I hope you take away is that you really do have a role in this. We're here to help you do that. So Dr. Moore, did you have a question? I saw you pop up, and then we have about a few seconds left if you have anything.
No, my question got answered in the process of the discussion. Thank you.
Okay, great, great. Well, we are out of time, and I just want to thank you both, Dr. Alter and Dr. Harbin, so much. This was really great. I think you did such a great job helping to explain the path forward. I have struggled to try to communicate it in an effective way so that people can understand it. And you did a great job. And I appreciate all your time and the work that you're doing in this space. So thank you so much.